Welcome to Health and Wellness. I'm Dr. Jennifer Ashton. The number of women opting to give birth in this country by cesarean section is on the rise, even when there's no medical need. So here to weigh in on the pros and cons of elective C-sections is top New York City OBGYN and Director of Gynecology at Roosevelt Hospital, Dr. Jacques Moritz. Boy, are we going to get into it.
I'm going to get in trouble.
All right. Let's set some global perspective here.
Right.
In this country, the C-section rate hovers between about 25 and 30%.
Exactly.
In other parts of the world,
Right.
South America, Asia,
Right.
it's higher, right? Much higher.
It depends. Yeah, it can
All
be
right.
even higher.
What are those women thinking, and what do they know that American women are not thinking and don't know? And do you think it's going to get to that?
Right. Well, so let's just go historically. Let's use Brazil because everyone knows
Let's
Brazil.
use Brazil.
Body conscious and everything. Brazil was always the place for an elective C-section. That's pretty much where it started. Now, why is that? Now, I think the myth is that it was because they didn't want their vagina stretched, they didn't want anything coming
Good reason.
through, and that was, well, maybe a good reason. But, you know, the more I looked into that and the more Brazilian patients I have, they say it was really that the women were scared because the medical facilities weren't quite equipped as here, that they were actually doing it for their baby, and they thought it was safer, and
Okay.
the myth got out that it was safer for the baby, and they were basically doing what every woman would do when pregnant,
Sure.
doing the right thing for the baby. There was no monitoring, the hospitals weren't exactly at the level that we were,
Right.
and it was convenient for everybody, and that's how it started. I think it went from Brazil to over here. The most classic one is Beckham's wife, you know, which started with too posh to
Posh.
Posh. So, and the idea there was that she was going to have her elective scheduled C-section around his soccer schedule. And they said, well, you know, my
Really?
husband's busy too.
Right.
Maybe I'll do it around his schedule. Or I want to go on vacation here. Maybe I'll just schedule it. Why wait? And celebrities start this stuff, and then it's the trickle-down theory,
Right.
just as in home births. The celebrity started, and all of a sudden
Sure.
you have people that are wanting to do it. Celebrities are not who you base
Right.
how you deliver your child.
Right.
Because Angelina Jolie went to Africa and, you know, had...
You were not her obstetrician,
I was
we
not,
should say, right?
and had a jet on the tarmac and was ready to evacuate her, doesn't mean that somebody saying, oh, that's a cool idea, I think I'm going to try that. And that's a big problem because we're really
Right.
influenced by this celebrity kind of baby business.
Right. This isn't like checking into a nail salon. This is major abdominal surgery
Right.
with some major risks.
It is.
And because it's 2010 and people seem to think, you know, it's, for the most part, thank goodness in this country, very safe.
Right.
Let's just go that way.
Well, that's wrong. This is the real deal.
Sure.
You know, this is anesthesia. This is the risk of complications from surgery. This is the risk of having a blood clot go from your leg to your lung to lights out,
To finish it,
leaving the hospital
a liter
in
of
a
blood
box,
loss.
as we like to say.
A liter of blood loss.
Yeah, that's it. And that's, so now we're talking about the first C-section. Now, if you're planning on having another one, so now we have the second C-section, which all those risks just kind of
Go up.
increase. So people have to know that. This is
Sure.
not a joke.
What about the theory or the concept that, look, this is modern times, this is the United States of America, the paternalistic approach to the practice of medicine is really done. Patient autonomy matters a lot. If a patient comes into your office and says, I want an elective C-section and I will go doctor to doctor until I find someone who will do it, is that wrong?
No, I personally don't think that that's wrong. I don't think that that's wrong, but I think that the patient has to bring it up. It's different than a doctor telling every pregnant woman, oh, I'm sorry, would you like an elective C-section? I said, oh, I didn't know that was an option.
Right,
That's,
right.
I don't think that's right. And
Right.
there are some places that do that. And the doctor will say, well, I'm just giving every option from home birth to elective C-section. Well, I don't talk about home birth, and I don't talk about elective C-section. If somebody comes to me to talk about those, we can have the discussion. Second, I think it's very, very important that a doctor, me, you, get a second opinion, making sure that this patient really understands it, making sure that I didn't sway it one way or another. Hear from a different source about whether you really want to go through this elective C-section.
You talked about the risks to the mom. We know those. You and I have seen some major disasters after the run-of-the-mill elective scheduled C-section, whether it's the first one or subsequent ones.
Right.
We're going to talk about the risks to a baby. People think that if the baby comes out in a C-section in an operating room, it's always the safest. That's not always true.
Right.
So we're going to talk about that. right after we take a break for a word from our sponsor. Stay with us. All right, risks to the baby with an elective C-section. A lot of people think if the baby comes out in a controlled, scheduled, surgical environment, they're home free. Not always the case.
Not always the case, because believe it or not, the baby going through the vagina and all is kind of being squeezed. We know that. And that squeezing action may either stimulate the first gasp or may squeeze the water. Because remember, this baby's been an amphibian so far.
Right.
Squeeze the water out of the lungs so that the first breath isn't full of water.
Sure.
When you have an elective C-section, you don't get to hold your baby right away. There's a reason. There's a pediatrician in the room. You have a higher rate of TTN, which is transient. Basically, the baby can breathe fast for the first 24 hours because it was basically startled. The labor didn't start by itself. I mean, first thing you know, Jen's hand is in there pulling out, and the kid goes
not really ready for it.
And takes a deep breath of water instead of air, and then it has to get the water out. No long-term problems, but in the first 24 hours of your baby being in the ICU, not exactly the best experience for mother-baby experience.
Or baby, might not go over so well.
Right.
VBAC, vaginal birth after cesarean. Our percentage rate in this country is pretty low.
Right.
A lot of women feel robbed of an experience if they wind up having to have a C-section with their first baby. They want to deliver vaginally the second. There's pros and cons to this. It's a very involved discussion.
Right.
What do you think the most important things for people to know are?
I think judgment on this is the key thing. If you had a C-section for no reason, now hold on, what's no reason? The baby was breached, you never went into labor, you really had no choice, a VBAC makes sense. If you had a C-section very early because maybe it was a cord or something and you never really went through labor, a VBAC is a thing.
Fetal distress.
Fetal distress, it depends when. But here's the case that I don't like the VBAC on, and I'll go out on a limb and say it. If somebody comes to me and says, I had a 9-pound baby by C-section, I got to fully dilated, meaning that they were ready to push. They pushed for 3 hours, and yet the baby didn't come down and nothing happened, and they want to try again. It doesn't make any sense to me because, history repeats itself. And the second baby is going to be bigger than the first. And probably the same thing is going to happen again. So the VBAC is great for certain people. There is a risk of uterine rupture, which is why you need the IV, which you need the monitoring. You need to be in the hospital. This is not a home birth situation at all. You can still have a midwife, but there has to be a doctor around in case this terrible side effect occurs.
Right.
But judgment should be used. There should be a scale of successfulness, if you will. The national numbers about 70% of people will be able to achieve a VBAC. I think it depends on your past history. So past history is important on this one.
Key point, obviously, and we can't emphasize it enough, it has to be individualized between a doctor and a patient.
Right.
It's not a one-size-fits-all thing. And as you and I both know, when you're dealing with pregnant women, there's at least 2, sometimes 3 lives at stake. And most of the time, we're lucky things turn out fine. Right. But when they go south, they go south fast. Thank you for joining us.
It's good seeing you.
And likewise, you'll have to come back when you have more than 30 seconds.
I will. I have somebody in labor, so I have to
go. You got to go. And thank you for joining us for another episode of Health and Wellness. I'm Dr. Jennifer Ashton. Until next time, wishing you good health.